Florida spent 3 straight enrollment seasons selling a simple promise: more plans, lower premiums, and the most generous drug coverage in the country. Seniors poured in from New York, New Jersey, and the Midwest, confident that retiring in the Sunshine State meant more than beaches and golf. It meant security. No one in Tallahassee questioned whether that security was real. They pointed to the numbers. More than 4.8 million Medicare beneficiaries statewide, dozens of Part D and Medicare Advantage drug plans per county, $0 premium options advertised on billboards along Interstate 95. Every election cycle, the governor's office highlighted Florida as proof that free market competition could protect retirees from Washington's policy swings. For a moment, it looked like they were right. Brokers wrote policies faster than they could answer voicemails. Senior centers held enrollment fairs with lines out the door. The system seemed built for endless growth. The larger the Medicare population got, the more leverage Florida appeared to have. More members meant more carrier interest. More carrier interest meant richer benefits. The feedback loop felt unstoppable. But the demand that made Florida look invincible was never just about population. It was about behavior. Retirees who used to split time between 2 states started switching their primary address to Florida because the drug plans here covered more pharmacies, more mail-order options, and more name-brand medications at lower tiers. Snowbirds who once kept their home state plans found themselves nudged into Florida's network because brokers told them the benefits were too good to pass up. By 2024, counties like Palm Beach, Lee, and Collier had Medicare penetration levels the rest of the country could not touch. Nearly half the residents in some zip codes were on Medicare drug plans, and the state kept adding more every quarter. Every new arrival meant another plan comparison, another formulary match, another victory for the narrative that Florida had cracked the code. Behind the scenes, the pressure was already building. The Inflation Reduction Act capped insulin and began phasing in catastrophic cost limits. On paper, that looked like a win for seniors. In reality, those costs shifted onto the private plans that dominated Florida's market. The more people enrolled, the more expensive the promises became. Federal policy was writing the benefits. Florida's carriers were expected to absorb the bill. No one said it out loud, but the math was changing. The same surge in retirees that made Florida look like a model state was also loading the system with a level of drug liability no insurer wanted. For a while, no one noticed. Seniors got cheaper insulin, politicians got talking points, carriers got member growth that pleased shareholders. The structure held, the charts went up, and every broker in the state repeated the same line: Florida is the place to retire because the drug plans here always deliver. That line worked right up until the day it didn't. By late 2024, Florida looked untouchable. Seniors could scroll through more than a dozen standalone drug plans in almost every major county, many advertising $0 premiums, $5 generics, and a $35 insulin cap that felt like a safety net wrapped in sunshine. National carriers poured marketing money into the state. Call centers ran overtime. Broker commissions flowed. Medicare Advantage plans bundled vision, dental, grocery cards, and gym memberships while still including full Part D coverage. The message was simple: retire in Florida, and you will never worry about prescriptions again. Morning news segments treated it like a breakthrough. Politicians cut ribbon after ribbon at new senior housing developments. Even the governor's office framed the drug benefit landscape as proof that Florida had solved what Washington could not. More choice, more benefits, less cost. For a moment, it looked like the perfect system. But the headlines missed the fine print. The Inflation Reduction Act changed the payout rules on the back end. In 2025, when catastrophic coverage shifted, private plans were suddenly responsible for a much larger share of high-cost drugs. Federal law required the new cap. The carriers were left to figure out how to pay for it. That pressure did not show up in campaign speeches or glossy brochures. It showed up in actuarial files and internal risk charts that never make the evening news. The benefits stayed generous because no one wanted to be the first plan to pull back. As long as one carrier offered a $0 premium plan, with brand drugs on Tier 3, the rest had to match it or lose market share. The race was no longer about seniors. It was about not being the first to blink. Florida's drug plan boom was never built on stability. It was built on competition and delay. Everyone pretended the bill would come later. Later arrived faster than expected. Carriers ran the numbers for 2025 and saw what the public never saw. The more members they gained, the more catastrophic liability they inherited. Growth did not solve the problem. It multiplied it. The same counties that bragged about having the most plan options were now the ones with the highest cost exposure. Florida's apparent strength was exactly what made it fragile. The exits began quietly. A national carrier trimmed its standalone Part D lineup, pulling plans from several Florida counties with little explanation beyond updated bidding strategy. Another reduced its footprint and mapped members into replacement plans with fewer covered drugs. A third waved off renewals entirely, telling brokers the margins no longer worked. The pattern repeated across the state. Seniors opened letters saying their plan would not exist next year, and they needed to choose a new one. Brokers watched their enrollment platforms shrink. What looked like an abundant choice on paper dissolved once specific drugs were entered into the formulary search. If a member needed insulin, a GLP-1, and one specialty cancer drug, the list of viable plans dropped from a dozen to 2, sometimes to none. Dominoes fell fast. Each exit shifted older and sicker members into the remaining plans, raising next year's costs before the year even started. Pharmacies began refusing certain fills until patients confirmed their new plan assignment. Seniors who thought they were protected discovered their most important medication had moved to a higher tier or required pre-authorization. Every carrier blamed the same triad: federal rule changes, runaway drug pricing, and actuarial math that no longer balanced. The boom had not ended with a bang. It ended with a quiet sentence in a non-renewal notice. Your plan will not be offered next year. On paper, the average Part D premium for 2025 looked like a gift. Federal reports showed a slight decrease, and press releases repeated the same talking point: drug coverage is getting cheaper. But anyone sitting across from a Florida retiree knew the truth. The premium was the smallest part of the bill. The real cost lived inside the structure. Higher deductibles, tighter formularies, prior authorization hurdles, and lost access to specialty medications were the real cost. New prior authorization rules and specialty tiers turned a single prescription into a second mortgage. A plan could advertise $35 insulin, then bury every other name brand drug behind a wall of paperwork and appeals. Seniors were not saving money. They were paying with time, stress, and uncertainty. The middle of the market felt it first, not the poorest seniors on Medicaid, not the wealthy retirees with cash reserves. The squeeze landed on the people who spent their lives working modest jobs, built modest savings, and now fell just above the income line for financial help. They earned too much for subsidies, but not enough to absorb a surprise $200 refill. Every new rule change forced them into the same conversation: keep the plan and give up a drug, or switch plans and give up a pharmacy. Brokers stopped talking about the best plan. They started talking about the least damaging one. The math was brutal. A retiree in Broward on 4 medications could face a deductible that reset every January, a prior authorization fight every spring, and a tiering exception denial every summer. By fall, they were paying full retail for a drug they once got for $30. The government measured affordability by average premium. Seniors measured it by the moment they stood at the counter and were told the full price. The difference between those two definitions was the gap the entire system fell into. Choice did not fix the problem, it exposed it. A Medicare search tool in Miami might list 12 standalone drug plans. Enter a specialty cancer drug and 10 disappear. Add a GLP-1, and the final 2 require mail order or a pharmacy 2 cities away. The plans existed on paper. They collapsed in reality. Seniors did not lose coverage because the government took it away. They lost it because the replacement plans did not cover the drugs that kept them alive. By the start of the 2025 enrollment window, the market was flooded with stranded beneficiaries. They had plans. They did not have access. The calls to brokers sounded identical. My plan is gone. My drug is not covered. What am I supposed to do? Agents refreshed their portals, only to find fewer and fewer plans left that would take high-cost members without punishing them for it. The system did not run out of policies. It ran out of workable matches. The stories piled up. A retired teacher in Palm Beach selected a new plan on October 15th, only to learn 2 weeks later that her pharmacy was out of network. A widower in Naples picked a low-premium plan, then found out his heart medication required prior authorization that would take 45 days. A couple in Fort Myers missed the deadline entirely and paid $900 out of pocket in January. None of them were victims of bad luck. They were casualties of a market that still looked full, but was already hollowing out from the inside. What happened in South Florida's condo towers is now happening in Florida's drug plans. The inventory is there. The usability is gone. Seniors can scroll through options, but once they press the button that matters, the coverage evaporates. The boom did not end with the disappearance of plans. It ended with the disappearance of plans that worked. October 1st, 6 in the morning, the first wave of federal non-renewal notices hit inboxes and mailboxes across Florida. The letters were short, clinical, and devastating. Your Medicare drug plan will not be offered next year. You will need to select a new plan during the upcoming enrollment period. By 8:30, Shine phone lines were already backed up. Hold music looped for 40 minutes at a time. Senior centers in Broward unlocked their doors to find lines forming before the staff even arrived. Brokers opened their laptops and watched their dashboards bleed. Entire client lists marked red. Every one of them suddenly unassigned. Every one of them is now desperate. By noon, the panic had a rhythm. A retiree in Boca held a notice in one hand and an insulin box in the other. A broker in Sarasota explained, for the 20th time, that no, the government did not cancel your coverage. The carrier withdrew the plan. A couple in Fort Myers tried to switch plans, but were told their cancer drug was not on any remaining formulary without a specialty tier penalty. The cancellations did not feel like policy changes. They felt like evictions. Carriers made the next move. They issued temporary enrollment holds in several Florida counties while they recalculated drug risk under the new catastrophic cap. If a plan covered too many high-cost drugs in a concentrated area, the risk pool flipped from profitable to impossible. Some paused enrollment in real time. Others pulled plan listings for entire zip codes. The message spread fast. Your plan might exist, but you might not be allowed into it. The system did not slow down. It seized. Title agents never had to approve a prescription refill. Brokers did, and when their portals started returning error messages, the collapse was instant. Seniors who thought they could shop calmly through November found out they had hours, not weeks. Not because the deadline changed, because the plans did. The state tried to step in. The governor's office pushed out statements promising that no Florida senior would lose access to life-saving medication. Behind the scenes, staffers sent urgent emails to state health agencies, asking whether Florida could force carriers to offer temporary extensions or mandate a hold on terminations. The answer was the same every time. Medicare is federal. The state cannot rewrite Part D. That did not stop the tug of war. County-level aging agencies told seniors to wait until official guidance arrived before switching plans. Carriers told them to switch immediately or risk losing drug continuity. Brokers told them to pick something, anything, before the remaining plans filled up. 3 authorities, 3 different instructions, 1 ticking clock. The longer the argument dragged on, the worse the damage became. Seniors who hesitated missed their refill dates. Pharmacies refused to float $100 medications while the state and carriers argued. Some retirees paid full retail just to get through the week. Others rationed pills and waited for someone to take responsibility. The political standoff was not dramatic. It was slow, procedural, and invisible. A stack of emails moved between Tallahassee, federal offices, and carrier lobbyists. One memo asked whether the governor could declare a temporary drug coverage emergency. Another reply reminded them that Part D is not state-regulated. The same loop repeated until no one could pretend the system was still functioning. The result was not a compromise. It was silent. The market kept locking up, one plan at a time. Seniors kept calling, one refill at a time, and the state kept insisting help was coming, one press quote at a time. The crisis was no longer theoretical. It was standing at the pharmacy counter, holding a declined claim receipt. In the end, it was not the federal rules or the state promises that defined the moment. It was the gap between them, a space big enough for thousands of retirees to fall through. A policy failure with real names, real illnesses, and real costs, the kind no talking point can fix. Rural Florida felt the shock first. Counties that rarely make headlines saw their only remaining drug plans vanish from the market overnight. In places like Highlands, Marion, and Suwannee, retirees who relied on independent pharmacies woke up to find their coverage gone and their usual pharmacist out of options. The big carriers had focused their energy on coastal metros, where enrollment numbers were higher and profit margins wider. The smaller towns were left behind. Independent pharmacies tried to help, but they could not front the cost of expensive prescriptions, while seniors waited for replacement plans to process. Each refill became a negotiation, each delay another gap in treatment. The ripple spread fast. Snowbirds who kept homes in 2 states began using their northern addresses to access drug plans that still offered wider coverage. Enrollment systems flagged thousands of dual residences as people shifted policies across state lines to escape Florida's shrinking menu of options. The exodus was quiet but measurable. Capital and coverage were both leaving the state. Pharmacies in border regions of Alabama and Georgia reported a surge of new customers listing Florida addresses. It was the drug plan version of capital flight. Experts warned the damage would not be evenly distributed. Counties with high concentrations of retirees on multiple chronic medications faced the greatest risk. Plans in those areas carried the most exposure and would take the longest to stabilize. Every actuarial model pointed to the same conclusion. The cost curve in Florida was rising faster than the national average, and each carrier exit made the next one more likely. The state's biggest selling point, its retiree density, had become the same factor pushing insurers away. By the start of 2026, the numbers told a clear story. Florida seniors had enjoyed one of the most competitive drug plan markets in the nation just a year earlier. Now they faced record non-renewal notices, higher deductibles, and fewer choices. The Inflation Reduction Act's new rules shifted catastrophic costs onto the very carriers that powered Florida's system, and they responded by retreating. Nearly 3 million Americans lost their Medicare Part D insurer that year, and Florida carried a disproportionate share of that total. The cascade did not end with insurers. Brokers closed offices. Shine counselors fielded triple their usual caseload. Pharmacies cut hours to reduce losses on unpaid claims. Each layer of the system bent a little further until nothing functioned smoothly. Seniors who once compared plans for better perks were now comparing which ones still existed. For the first time, the question was not how to save money, but how to stay covered at all. What comes next is uncertain. Federal regulators say the new benefit design will stabilize prices over time. State officials insist Florida can adapt by attracting smaller regional carriers. Economists point to the data and see a different picture. A market built on aggressive competition has become one defined by retreat. The same population that made Florida the testing ground for Medicare innovation has become its warning sign. Florida's Part D crisis is more than a technical failure. It is a stress test of what happens when policy ambition collides with financial reality. The coverage map that once glittered with options now looks like a patchwork of disappearing promises. Whether the system rebuilds or erodes further will decide not just the future of Florida's retirees, but the credibility of Medicare itself.